The following podcast is part of a certified educational activity titled Cases in the Community, Optimizing Treatment and Considering Weight Management as a Primary Goal in People with Type 2 Diabetes. Access the entire activity and complete the post-test at peerview.com/ZKT860. Downloadable slides and practice aids are also available.
Hi, my name is Dr. Javier Morales. I'm Associate Clinical Professor of Medicine at the Donald and Barbara Zucker School of Medicine at Hofstra University, as well as the Vice President and Clinical Trials Investigator at the Advanced Internal Medicine Group in East Hills, New York. Welcome to this activity on type 2 diabetes and weight management. Our goals for today are to improve our abilities to prioritize weight loss as a treatment target in patients with type 2 diabetes, consistent with guideline recommendations. We'll also try to overcome therapeutic inertia by enhancing some of our communication skills, as well as to help to intensify therapy in a timely and appropriate manner when glycemic and weight goals are unmet. And finally, focus on decision-making skills to develop individualized management plans in hoping to address glycemia and weight in our patient population. When you have finished the activity, remember to download the slides and practice aids and complete the post-test for instant credit at peerview.com/ZKT. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent grant from Lilly. Let's focus on understanding the relationship between type 2 diabetes, obesity, and its consequences. Ruby is a woman aged 57 years who has a 7-year history of type 2 diabetes, obesity, and hypertension. Her A1C is 7.7%. Her BMI is 29 kilograms per meter squared, and her blood pressure is 141/91, all of which are slightly higher than at her previous office visit 6 months ago. Her current medications include metformin extended release 1,500 milligrams per day and lisinopril HCTZ 20/25. Ruby meets 3 different criteria in the ADA guidelines that would prioritize a GLP-1 receptor agonist or a GIP-GLP-1 coagonist as the next step in treatment. First, she has indicators of high risk for cardiorenal disease, that is, age 55 years or older, with 2 or more additional risk factors, which in her case are obesity and hypertension. Second, her A1C exceeds the generally recommended A1C goal of less than 7%. Third, Ruby would benefit from weight reduction. The longer individuals have overweight, the higher their cardiovascular risk. The ADA standards of care prioritize GLP-1 receptor agonists with proven cardiovascular benefit or an SGLT2 inhibitor with proven cardiovascular benefit as first-line medications for individuals at high cardiorenal risk. But Ruby's A1C and weight also need to be addressed. Higher efficacy approaches to reduce A1C include some GLP-1 receptor agonists, GIP-GLP-1 receptor coagonists, insulin, and combination oral or injectable therapy. The ADA standards recommend glucose-lowering agents that have both glycemic and weight loss efficacy when choosing glucose-lowering therapies for patients with type 2 diabetes who need to lose weight. Accordingly, some of the GLP-1 receptor agonists and a GIP-GLP-1 coagonist are prioritized. The ADA standards recommend nutrition, physical activity, and behavioral therapy to achieve and maintain at least 5% weight loss for people with type 2 diabetes and overweight or obesity. There's no question that walking at least 150 minutes per week is helpful, but walking alone is unlikely to get Ruby to her goals. Even with the very intensive lifestyle intervention used in the Look Ahead trial, hemoglobin A1C was reduced by only 0.22% over 10 years. And only about half were able to sustain 5% weight loss or more over 8 years. Adding an SGLT2 inhibitor would address Ruby's elevated A1C and cardiorenal risks, but with lower weight reduction efficacy than some GLP-1 receptor agonists or GIP-GLP-1 coagonists. Moreover, GLP-1 receptor agonists or a GIP-GLP-1 receptor coagonist and SGLT2 inhibitors may also reduce blood pressure, although they're not indicated for this purpose. It's worth noting that the semaglutide obesity studies demonstrated that there was a reduction in the progression to overt diabetes in overweight individuals at risk. Galen is a 70-year-old with a prior history of stroke who's overweight with a BMI of 27. He's got chronic kidney disease with a GFR of 50 and a urine albumin to creatinine ratio at 40. He's got a 15-year history of type 2 diabetes, so he's certainly at increased risk of additional cardiovascular events. He's currently using basal insulin and an SGLT2 for glycemic control. Given his history of stroke and type 2 diabetes and chronic kidney disease, Galen is at high cardiovascular risk. He's already using an SGLT2 inhibitor. Adding a GLP-1 receptor agonist may offer Galen multiple glycemic and non-glycemic benefits, including lower hemoglobin A1C, as well as weight reduction. The choice of GLP-1 based therapy is important for someone like Galen. Reduce risk of atherosclerotic cardiovascular disease events if dulaglutide, liraglutide, or semaglutide is selected is achievable. Pooled clinical trial results from the GIP-GLP-1 coagonist tirzepatide suggests cardiovascular benefits, but the SURPASS cardiovascular outcomes study will provide definitive evidence. Moreover, evidence from cardiovascular outcomes trials indicate that some GLP-1 receptor agonists have the potential to slow the progression of chronic kidney disease. More recently, the FLOW trial was conducted looking specifically at semaglutide in patients with diabetes and chronic kidney disease. As a consequence of achieving the primary endpoint, the trial was stopped early. Galen is already on basal insulin, so you wouldn't add an insulin GLP-1 fixed ratio combination. The insulin GLP-1 fixed ratio combination is also a basal insulin, either glargine or degludec. Switching from a GLP-1 receptor agonist to an insulin GLP-1 fixed ratio combination would offer glycemic benefits, but not weight benefits, although Galen doesn't need to lose much weight. 2 fixed ratio combinations are currently available: glargine in combination with the short-acting GLP-1 lixisenatide, and insulin degludec with the longer-acting GLP-1 liraglutide. Dedicated cardiovascular outcome trials haven't been reported for either fixed ratio combination, but glargine, lixisenatide, and degludec all have neutral effects on cardiovascular outcomes. Liraglutide reduces major adverse cardiovascular events at the 1.2 milligram and 1.8 milligram per day dose, but we may not get to these doses with a fixed ratio combination. Adding a DPP-4 inhibitor, prandial insulin, or metformin would offer glycemic benefits, but not weight, atherosclerotic cardiovascular disease, or kidney benefits. Concurrent use of 2 SGLT2 inhibitors has not been studied. The Look Ahead study was a pivotal trial looking at patients with type 2 diabetes that were randomized to intensive lifestyle intervention compared to diabetes support and education offered. Even in the Look Ahead study, which used a very intensive lifestyle modification with frequent clinic visits and follow-up, only minimal long-term changes in hemoglobin A1C and weight were observed. Moreover, only 27% of participants were able to maintain 10% or more weight loss over 8 years. While a busy slide tells the story, and that is looking at microvascular complications, which include retinopathy, neuropathy, and nephropathy, macrovascular complications, which include cardiovascular events or stroke events, or mortality, tend to be increased with the longer duration that the patient experiences higher hemoglobin A1C. So we really want to get the A1C under control and keep it there. The longer patients are exposed to an elevated hemoglobin A1C, the worse their outcomes. This is sometimes referred to as a negative legacy effect. Persisting with lifestyle modifications alone in patients with hemoglobin A1Cs that are 1 to 2% above goal is a recipe for clinical inertia. As part of its Overcoming Therapeutic Inertia initiative, the ADA advocates for adjusting therapy any time a patient's A1C, fasting, or postprandial targets are not at goal. Utilizing blood glucose monitoring data in between hemoglobin A1C testing is recommended. Overcoming Therapeutic Inertia recommends adjusting therapy every 2 to 3 months for patients with an A1C of 7 to 8.9%. So clinical inertia is dangerous and deadly. Here we're looking at the relative risk increase in myocardial infarction, stroke, heart failure, or the composite outcome. And what we can see here is that for every year that the hemoglobin A1C is in excess of 7%, compared to those who have a hemoglobin A1C of less than 7%, there is a significant increase in all of these adverse cardiovascular events listed, including the composite. We also see a negative legacy effect with respect to the duration of overweight and physical activity. Overweight and inactivity leads to worse outcomes than being overweight and active. The way that we speak to our patients affects their relationships with us. Flatly, telling patients that their plan is unrealistic is likely to be received as a put-down and may cause them to become defensive. When patients feel demeaned or dismissed, they become distrustful, leading to delayed or avoided care or even switching providers. Patient-centered communication should be a hallmark of every conversation between patient and provider. And shared decision-making has been a feature of the ADA guidelines since 2013. Shared decision-making used with patient-centered communication improves satisfaction with care, and importantly, there are ways of incorporating shared decision-making that don't add time to the office visit. Up-titrating monotherapy does not yield big changes in hemoglobin A1C. For example, let's consider metformin. The prescribing information for metformin extended release shows that after 16 weeks of treatment for patients starting from a baseline A1C of about 8.4%, going to 1,500 milligrams once daily reduces A1C by about 0.9%. At 2,000 milligrams once daily, reduces A1C by about 0.8%. And 1,000 milligrams twice daily reduces A1C by about 1.1%. Switching from 1,500 milligrams per day to 2,000 milligrams per day of metformin won't be expected to produce more than an additional 0.3% reduction in hemoglobin A1C. Recognizing the difficulties associated with reducing A1C by 2% or more, the ADA and EASD, as well as the DCRM multi-specialty practice recommendations, advocate instituting combination therapy as needed to meet individualized glycemic goals. The ADA standards of care prioritize semaglutide and tirzepatide for their very high glycemic and weight loss efficacy. Dulaglutide or liraglutide are associated with high glycemic and weight loss efficacy. All other GLP-1 receptor agonists and all the SGLT2s have intermediate efficacy, and DPP-4 inhibitors such as sitagliptin and metformin are considered weight neutral. Pioglitazone has high glycemic efficacy but is associated with weight gain. ADA guidelines and DCRM guidelines advise against using a GLP-1 receptor agonist or a GIP-GLP-1 receptor coagonist along with a DPP-4 inhibitor. Part of the reason for this is because inhibiting DPP-4 allows endogenously produced GLP-1 to remain at physiologic levels. Meanwhile, when giving a GLP-1 receptor agonist or a GIP-GLP-1 receptor coagonist exogenously, we will be giving supraphysiologic doses of GLP-1. So inhibition of DPP-4 is not necessary. In patients with type 2 diabetes using DPP-4 inhibitors, discontinue the DPP-4 inhibitor before starting a GLP-1 receptor agonist or a GIP-GLP-1 receptor coagonist. Don't double up on incretins either. Please don't use 2 different DPP-4 inhibitors, and please don't use 2 different GLP-1 based treatments. GLP-1 receptor agonists and GLP-1 GIP coagonists work via glucose-dependent insulin secretion. They have only a small effect on A1C when glucose levels are near normal. So why not use a CGM or a continuous glucose monitor? After all, CGM is a wonderful tool to troubleshoot the causes of an elevated hemoglobin A1C. Both personal or professional CGM are recommended by the ADA guidelines after therapeutic intensification. Professional CGM is ideal for situations where there is a temporary need for close monitoring of glycemia. The device is owned by the healthcare professional, provided as needed to patients, and billed to the patient. Personal CGM shows patients very clearly how food choices and physical activity affect glycemia. There's even a new over-the-counter personal CGM device that was recently approved for patients who are not using insulin. It's expected to be available for purchase soon. There is one little caveat, however, and that is the potentials of overestimation of hypoglycemia. Accuracy tends to be, less accurate at near normal blood glucose levels with some of these CGM devices. But neither professional nor personal CGM are recommended as interventions for elevated weight. Several studies have demonstrated diabetes remission following weight loss. Weight loss of approximately 10 to 15% was needed to induce remission at 1 year in about half of individuals with short-duration type 2 diabetes in the DIRECT study, where remission was defined as a hemoglobin A1C of less than 6.5% persisting for at least 3 months without glucose-lowering medications. Weight loss of approximately 13 kilograms, or 10 to 15%, was needed to induce remission at 2 or more study visits over 1 year in about 11% of individuals with type 2 diabetes in the intensive therapy group in the Look Ahead study, where remission was defined as an A1C of less than 6.5% without glucose-lowering medications at each visit. The ARMS type 2 diabetes study, a pooled analysis of 4 random control trials, reported data for up to 12 years post-bariatric surgery and found that a minority of patients sustained diabetes remission in long-term follow-up, about 18% of the bariatric surgery group and 6.2% of the medical therapy lifestyle group. The remission was defined as an A1C of less than 6.5% and not receiving any medications for diabetes. The likelihood of sustained drug-free remission of diabetes is higher with shorter disease duration and lower A1C at baseline. The management of type 2 diabetes and obesity is not easy and oftentimes can be a vicious cycle, but we can actually convert this to a virtuous cycle. And the way that we can achieve this is really through the shared decision-making process by setting achievable, realistic goals and then developing a manageable plan in order to achieve that goal. Once that goal is met, that means a plan is working, which is actually quite good and encouraging for the patient. The stress is reduced. There is an encouragement of adherence to the plan that has been put into place and even introduction of new goals. So through the shared decision-making process and use of agents that include the GLP-1 receptor agonists or GIP GLP-1 coagonists in patients with type 2 diabetes, oftentimes will often help to lead to adaptation of healthful behaviors through dietary modification, increased exercise, increasing the likelihood of success. The range of weight loss that any given individual attains varies for all types of interventions, whether lifestyle modifications, pharmacotherapy, or surgical procedures. Some individuals will lose much more weight than others, and some will actually gain weight. But the amount of weight loss with GLP-1 receptor agonists or the GIP GLP-1 coagonist is not random, and it is appropriate to set time-related weight loss goals. The mean weight loss over 1 year in clinical trials of GLP-1 receptor agonists or GIP GLP-1 coagonists ranged from about 6% to 15%. This is why it is important to assess progress toward weight loss goals soon after initiating a weight loss intervention. Switching to a different strategy may be better than adhering to a strategy that's not working. Individuals with type 2 diabetes tend to lose less weight with any given intervention than individuals who do not have type 2 diabetes. Patient-centered communication should be a hallmark of every conversation between patient and provider, and is especially important for patients with ambitious health goals. Shared decision-making used with patient-centered communication improves satisfaction with care. The highest mean weight loss observed in clinical trials was for tirzepatide 15 milligrams at 72 weeks in the SURMOUNT-2 and at 40 weeks in the SURPASS-1 clinical trials, with 14.7% and 11% weight reductions from baseline respectively. Semaglutide 2.4 milligrams resulted in 9.6% weight reduction from baseline at 68 weeks in the STEP 2 trial. Semaglutide 2 milligrams resulted in 6.9% weight reduction from baseline at 40 weeks in the SUSTAIN FORTE trial. Liraglutide 3 milligrams resulted in 6% weight reduction from baseline at 56 weeks in the SCALE diabetes trial. Dulaglutide 4.5 milligrams resulted in 5 kilogram weight loss from baseline at 52 weeks in the AWARD 11 trial. Smaller proportions of participants in these trials lost 20% or more of their weight from baseline, 31% in SURMOUNT-2, 13% in STEP 2. The proportion of patients losing 20% or more of their weight from baseline were not reported for SURPASS-1, SUSTAIN FORTE, SCALE diabetes, or AWARD 11. The amounts of weight lost under real-world conditions may be lower than the amounts observed in clinical trials. Data from a Texas health system registry showed that after 12 months of treatment with semaglutide, 4% of individuals with type 2 diabetes had lost 20% or more of their weight, while 35% had not lost any weight. In summary, although a weight loss of 20% is a more than average amount to lose within a year, it may be possible with tirzepatide or semaglutide and is more likely at the maximum approved doses.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/ZKT860. This activity is supported by an educational grant from Lilly.